Welcome to our town hall, and I'm Dr. Hope Rugo at the University of California, San Francisco, where I'm a breast medical oncologist.
Hi guys, this is Hossein Borghael. I'm a thoracic medical oncologist at Fox Chase Cancer Center here in Philadelphia.
Welcome to our town hall. We're joined today by our colleagues, Dr. Jack Leighton, who's a GI oncologist at Einstein Hospital in Northern Philadelphia, and Dr. Mohammed Abbasi, who's an oncologist in Central North New Jersey, and Dr. Martha Mann, who's an oncologist here in the Bay Area, in the South Bay Area at a community oncology center run by Stanford Hospital. So we're very excited to have all of you here and appreciate you participating. Thank you. So we'll start today, I think, by just having everybody tell us a little bit about what they've been doing in their practices and the impact of COVID-19. So first tell us a little bit about yourselves and then something about your practice. So we'll start with Dr. Jack Leighton, who's in, as I mentioned before, Philadelphia. Jack.
Good morning. Thank you for having me, and thank you everybody for joining. I'm a medical oncologist with a primary interest in GI medical oncology. I work in the Einstein Health Network in Philadelphia and in Montgomery County. We have an 8-person group of medical oncologists and hematologists. I think anybody who's read some of the media in Philadelphia has seen that our hospital has been hit hard by the COVID pandemic, but we've been providing terrific care to the patients. Much of the hospital is patients with COVID-19. We've been involved with hematology consults on the inpatient side. On the outpatient side, like I think everybody, we've needed to make many adjustments. We don't allow visitors in our cancer centers now with patients. We screen our patients and we screen our staff every day with questions and with temperatures to make sure we're providing the safest possible environment for our patients who need to come in and receive treatments. I think it's very scary for patients to have to come to the hospital, but we try to make adjustments to regimens, but many patients do need to come in and keep their treatments on time, and we want things to be safe for them. We've transitioned many follow-up visits and patients on oral therapies to telehealth visits, and it's amazing how well that has come up, how quickly. There are challenges because we do live in an area where there are socioeconomic disparities, and the technology is not always what we would like it to be. Ideally, we would meet with our patients through a video portal so we can not only speak with them, but be able to assess them. But some patients may have flip phones and we have to do telephone calls with them, which is better than not communicating. But sometimes you feel you don't get the whole picture. You know, for those of us who've been doing this for a while, we do feel there are things on the physical exam that we still want to carry out that we can't do through these telehealth channels. But I agree with what's been out there that telemedicine will be here to stay when the pandemic is over, and we'll need to make adjustments. Our focus moving forward is trying to bring back patients to our cancer center, hopefully in the next few weeks. Our doctors who provide us patients, our gastroenterologists, our mammographers, our breast surgeons, will be able to be back up and running, and we can provide a safe environment for our patients.
That's great. Dr. Borghael, do you want to?
Sure. Jack, that was great. Thanks a lot. Let's go next to Dr. Abbasi. Please tell us a little bit about your practice and what you have been experiencing.
Yeah, thank you. Thank you, everyone. And I hope and pray all who are watching and seeing this program are well and safe. And thank you, Dr. Borghael and Dr. Rugo and Axiom to arrange this very important topic, especially for us, the community oncologists, who we are facing challenges with our patient, but also as caregivers, we are facing challenges ourselves. So That's a very good topic and good timing, and appreciate that. We practice in northern New Jersey, as you know, central northern Jersey, just like Philly and other northern east states, hit badly with the COVID. And certain challenges come because we are a group of physicians who are physician-owned practice, which is a shrinking actually group of community oncologists. And as I just want to remind everybody, about 55% of the cancer care delivered in the US is delivered by the community oncologists. So it's a huge group, which first, you know, a group of doctors who are dealing with the patients. So in our group, there are blessings also being a physician-owned practice, because then we can make many decisions about running the practice and also seeing the patients from physician's perspective, not only business perspective, but the physicians. So just give you an example, when this COVID hit, right overnight, we made a decision as a practice. Some changes were made, dramatic changes actually. One of them was to close the practice and cut down the number of visits, both by the patient as well as the staff in the office. And in fact, the interesting thing that we did is that we put a tent outside our office in the parking lot. We named it Park and Poke. So patients come and get the blood drawn, and they don't have to come in and they leave. And then later on, we do, as my colleague mentioned, about telemedicine, which is offering about 40% of our visits now are telemedicine visits, which it has a unique situation actually. As I was thinking about this, seeing a patient first time on a televisit is not an ideal situation, especially for the cancer patients. But we are coming up with the situations and ways where we have family together with the patient and we discuss with them. It's a better situation than having patient only in the office. Some of the other things that we have done in our office to mitigate the effects of spread is to limit only patient coming into the office, deep cleaning the office 3 times a week, distancing between the chairs. So just give you an example, we have 20 chairs in the office, so we are using only 10 so that we have distance. And all these measures, our staff also cut down the staff. In fact, one of our colleagues in the last town hall meeting, I was impressed that he was mentioning about the Singapore model of care, where they have least number of patients and least number of staff at a given time in the office. And luckily we were doing from the very first day, just being a physician running the practice, we were able to come up with this plan. And actually it's interesting that we just done a testing of all our 60 employees in our office. All of them, we did antibody tests to see what we have done last few months, how many employees actually are carrier or were exposed. And interestingly, I'm very happy to see that only 3 of them, and 2 of them actually we knew because they had COVID exposure and they were sick and they were taken out of the office. The reason this is important and helpful, that we were able to do whatever we did, actually protected our staff as well as our patients. And I don't remember any single patient in our practice who has COVID related sickness. So that's a great thing. Being a small practice with a lot of challenges, as you know, running a payroll. In addition to, we have to put 2 hats, not only hat of a physician and thing, making all the decisions about the chemotherapy, delaying the chemotherapy, changing the oral agents, but also thinking about his staff, how to run the office. We have to furlough about 1/3 of our staff in the first week, but luckily we were able to hire them all back with some loans that is available to us, the private practice, and also some help from the HHS. So I think these challenges are very real, and to real group of doctors who are literally, for us, I would say to our practice, like our practice, many of them, 1, 2 doctor practice, 3 doctors, we are 6 of us in our practice. So these small to mid-sized practices have unique challenges, which I think are very important, and I appreciate this forum to discuss those.
That's great. Thank you so much for sharing that. We're going to come back to a lot of the concepts that you raised. We already have a couple of questions that I think we need to address. So thanks for that. Dr. Rugo?
It's really impressive that you were able to keep everybody on after the initial furloughing. And I think that's such an incredibly important part of the effort to try and at least do our own little bits to protect the financial well-being of the United States now, where we're really suffering so much. Martha, you work in South Bay, so northern part of California. Tell us a little bit about your experience and what you do.
Yes, hi. Thank you very much for asking me to be part of this webinar. This is a really, really great topic and very, very timely. After fellowship, I initially worked for an independent freestanding private practice, sounds like Dr. Abbasi's situation. And then in 2015, we moved our practice to become part of a community cancer center built by Stanford in the San Jose area. So I've been there since that time. Just like the other physicians, I can certainly see there's been significant changes in how this COVID pandemic has changed our care in both the outpatient and the inpatient setting. We have, of course, had to drastically reduce the inpatient volume of visits to our clinic for the safety of our immunocompromised patients, our patients on chemotherapy, for the safety of our staff. So prior to visits, patients are getting screening phone calls asking about infection symptoms, respiratory symptoms, asked to reschedule if they're having any of these symptoms, and certainly directed to appropriate care centers if they are having concerning symptoms for COVID. When patients arrive at the clinic, they are greeted at the front. They are all given masks and also asked screening questions. Initially, we had done temperature screenings, but interestingly, I guess Stanford looked at over 20,000 patient encounters and found that out of all those, less than 10 people actually had fever when they showed up to the clinic. So this week, we actually stopped the temperature screening since it seemed that patients were actually pretty good judges of whether they had a fever or not. So that's one thing that was just recently changed. As the other physicians had mentioned, there's been a big push to offering video visits. The goal has been to try to make at least 50% of our visits be video visits. But there's definitely the challenges. I practice in the Silicon Valley. There should be, good quality internet service here, but there can still be problems with bandwidth being overwhelmed by the work Zoom meetings and the virtual school, and just, again, problems with patients not feeling as comfortable with using that kind of technology. But it's nice to be able to at least offer patients the opportunity to continue to have that connection. Just as Dr. Abbasi was saying, though, I think that these kind of visits seem to work best for patients who are longstanding patients of mine, who are very stable on oral medications. I have done some new patient visits on Zoom, and I've actually had a patient who requested to subsequently later meet me in person because it was just maybe just not getting quite the right feel or the right connection over the Zoom meeting. The other thing that we are doing more now, of course, is telephone visits. Recently, I think it was in the beginning of March, CMS did offer the option of being able to bill for telephone visits, which was not always an option previously. And we all spent quite a lot of time talking on the phone to patients. And actually on April 30th, I saw a notice that they were actually going to increase the E&M code so that you could actually bill the same for a video or in-person visit as you can for a telephone visit based on time spent. And that, kind of income, of course, is very vital for a small practice where the margins can be very thin. So having at least that option of trying to maintain income to keep the practice open is important. Just to touch on coronavirus screening, so this was also mentioned by some of the other physicians. Stanford recently did a push to test all of the providers and staff across the whole organization. They had been testing every patient who was starting radiation therapy due to the need for very frequent visits to come to the medical center. And we've just recently started instituting coronavirus screening for every patient who was a new patient starting chemotherapy, also offering this option to older patients who are on treatment, and patients coming in for surgeries and procedures. Part of this reflects the testing capacity, so this is through Stanford's own coronavirus assays. So offering the swab testing as well as antibody testing to all of these patients. In terms of the inpatient setting, so the way my group does it is that we spend a week in the time at the hospital. We divide up the hospital rounding. So we have one person covering all of the hospitals and taking care of all the hospital patients for a week at a time. Here in the San Jose area, we are fortunate. The hospitals are not overwhelmed. If anything, the hospital volume is down significantly, as patients are not wanting to be hospitalized, and there's been a dramatic reduction in elective procedures. I will say they took the oncology floor and converted it to a respiratory isolation unit because it was already set up for, single occupancy rooms. So that made the oncology patients be scattered all over the hospital and the nursing care be scattered all over the hospital. So that does have issues with, the quality of care those oncology patients are getting. Perhaps the most heartbreaking thing, of course, is that there are no visitors or family permitted to come and visit the patients in the hospital. So it's very hard to have these tough conversations, newly diagnosed or disease progression, or certainly end-of-life discussions with the patients when they're totally alone in the hospital. You can try to, of course, talk to family over the phone or patch them in by phone, but they're not getting the same level of emotional support. I'll just touch on one other thing, one other aspect that I've thought about, with this coronavirus pandemic is it's how it's changing the human side of providing medical care. It's already scary for patients to see an oncologist for the first time and then to walk in there wearing a gown and a face shield and a mask. And, there's already a lot of, physical distancing that's coming with all that. And I've discovered that, when you're trying to give care to patients and we're both wearing masks, it's hard to assess their emotions, their level of understanding to what you're saying. We take a lot of cues from their emotional reaction to what we're saying. It's also harder for me to express empathy when they can't see my facial expression and I can't shake their hand or give them a hug or give them, a touch or give them some comfort in this difficult time. So obviously we hope someday we can do that again.
Yeah, I think one of the big areas for many of our patients now is what the future will have as well. I think it's been really quite an amazing time for all of us, and how things will open up and how we're going to protect everyone, given the fact that the virus isn't going away and we won't have a vaccine in the near future, is a big question. The testing is also an interesting question for asymptomatic patients. At UCSF, we haven't tested everyone, but certainly anyone who wants to be tested can be. But I think the testing, just for those who are listening in, the testing positivity rate, if you're asymptomatic, is minuscule, in the less than 1% range. Even in patients who are symptomatic, the positive rate is relatively low. So, unless you have a classic COVID-like symptom, but like an upper respiratory infection, the testing rate is relatively low. So we haven't been doing universal testing, but we have been testing everybody who's coming in for surgery, which has really opened up, or people coming into the hospital, really opened up the ability to do elective surgeries, which I think is great for our patients.
Dr. Rugo, let me ask you this. Compared to, let's say, 3 or 4 weeks ago, maybe it was 5 weeks ago, when we started doing these town halls, have you noticed any major changes at your center compared to now?
Well, I think that, we're probably the oddest group in a way to say that. I think just because the incidence of COVID-19 positivity and also serious illness has been so much lower on the West Coast than the East Coast, potentially due to both differences in migration patterns and differences in virus. As we heard more in the last couple of weeks, there's some changes and mutations in the virus that may make it different in terms of its severity of infection as well as its infectiousness, depending on where you are. So actually, that's been quite fascinating for us to understand as well. I think that, the main part for our treatment has been two. One is opening up surgery and screening. So doing mammography now, which is great, and being able to test people more frequently, get results back quickly makes a huge difference in being able to do those things. And then the second part of it is trying to open up our clinical trial accruals, which is a really important part of what we offer to our patients. For that, our clinical trial coordinators still cannot come to the medical center. So we have worked out, I think everybody has over the last couple of months, our DocuSign and being able to understand which clinical trials we can do and how to obtain research-only biopsies and bloods, which is really specific to being able to enroll on trials. But these trials are what lead to having agents that are new and provide additional options for patients. It's been nice for us to see that drugs continue to be approved. However, during this time and during the COVID pandemic, there have been 2 new drugs that have been approved for breast cancer, which really offer a tremendous amount of hope to our patients with metastatic disease. So that's been really a very nice thing to see, a continued access to these agents.
We've got 2 drugs were also approved in lung cancer just in the past week.
Which is amazing.
Targeted. Yeah, it is amazing. But obviously these studies were conducted a while ago, and the publications are coming out and the presentations are being planned. So I think it is amazing that all of that is going on. You touched upon one issue with the mammography and other screening. We have a question actually that how, Dr. Leighton, you might want to unmute yourself because you're still mute. How has this impacted screening for early disease in terms of the colonoscopies and mammographies? And there is some data that there's a tremendous reduction in, for instance, lung cancer screening even. Have you seen anything like that? Are you worried that we might be seeing more advanced stage patients coming into the clinics once these restrictions are lifted? Yeah, how do you guys see the data sort of developing? Maybe we can start with Dr. Mann.
Well, I can think with Dr. Rugo's experience, again, that thankfully the COVID pandemic has not impacted California as severely as other parts of the country. So there was certainly a hold put on endoscopic procedures, mammography, even breast surgeries for patients with very early stage low risk breast cancers or DCIS. Those were put on hold or postponed. I mean, that's very hard for patients to hear that. As of the beginning of May, however, a lot of the local hospitals, including Stanford, have opened up to offering the regular screening visits and rescheduling those exams that had been postponed. And I think even for endoscopy, particularly when patients can get access to testing beforehand, because those are higher risk procedures. I will say what I found was interesting, and maybe the other physicians can speak to this, is, for patients who were waiting for surgery, sometimes we ended up putting patients on neoadjuvant treatment, even though they had extremely small breast cancers. So neoadjuvant hormone therapy for patients with stage 1 breast cancer or even DCIS, per their preference. It gave them a sense that they were getting some treatment while they were waiting. And I've even seen some pathologic CRs for patients on short courses of hormone blocking therapy. So it makes me wonder if we should be considering this practice more in the future.
Yes, we should be. That's such an interesting thing, because I wonder how it's affected other cancers. So it would be really good to hear that, because we've been long proponents of neoadjuvant therapy. And I think that, hopefully people will not only be more comfortable with doing the occasional check-in by telemedicine, which we talked a lot about, but also by giving treatment up front so that you can understand the response to therapy, because I think that's a huge advance. I don't know, how has that been affecting for your practices, Dr. Abbasi?
Sure. As Dr. Mann mentioned, I think number of phone calls that we are receiving has gone up so significantly about, can I do this test now? Can I delay it for 2 months or 3 months? So this not only includes this mammogram or colonoscopies, but sometimes there are important tests. For example, a patient in the middle of the treatment who need assessment to whether chemo is working or not working. To answer your question about neoadjuvant, in fact, other cancers. So I recently saw a patient with ovarian cancer. She had relatively early stage disease that she could have just gone for surgery. In fact, she was scheduled for surgery, and right in the middle of this, and then it was canceled. So I got a call from the GYN oncologist to see if can you start the chemo first. So I'm giving her chemo right now instead of going for surgery, and so many other cases. The patients are really scared, not only going to the hospital, but anything affiliated with the hospital. So if somebody has a PET scan or CAT scan, a facility attached to the hospital, they're calling us, they're saying, we're not going, get me some other place away from the hospital, not close to the hospital. So we are seeing this a lot. I think many of those mammogram, for example, colonoscopy screening, we still can buy some time. I think those are, most of the time they're not urgent. So we can delay it for a few months, even 6 months sometime. But some other cases which are bothersome, for example, I had recently a lymphoma patient who really needed a PET scan before I started the chemotherapy, and he was refusing to go anywhere close. So I have to find a facility which is away from the hospital and in a settle-on facility. So these kind of challenges we are seeing with patients are reluctant to go to the hospital. They rather come to the office to visit. Just to make a point also, our practice is a very away from the hospital, right in the middle of the community, where we have a standalone facility. So patients prefer to come to us. Sometimes I got a call from, they don't want to go to the clinic in the hospital, although hospital clinic is protected and all those things, but they rather come to our office because they feel more homely and comfortable in that environment. So that we see quite a bit.
One of the big questions that's come up for our patients has been whether or not we're not treating patients. Are we giving patients less treatment, or are they making decisions to get less treatment? Do you deprioritize other treatments? Could people actually have a less good outcome from their cancer because of COVID? Jack, have you noticed, how have you dealt with that in your practice?
Sure, I'm just gonna quickly chip in because I just was talking on the topic, is that we did actually, as many of my colleagues I'm pretty sure have done, adjuvant treatment, some of the adjuvant that you can delay for a few more weeks after surgery, for example, breast cancer surgery. And instead of doing within 4 to 6 weeks, delayed 8 weeks, sometimes even beyond a little bit. So similarly, some of the other non-important treatment, for example, many of our patients were coming to the office for Xgeva, or Procrit, or IV iron infusions, and even immunotherapies, especially somebody who's already on immunotherapy and doing well, we can delay for a few months. So yes, this question is coming up, and sometimes patients raise this question. They say, what if I delayed because they're really scared? It all depends. I would say that when the whole COVID situation started, people were much more scared. In the last few weeks, I'm seeing the little change, that they are more comfortable with the situation now. They are having more control on the things. So they are more willing to come to the office, and we are actually doing more and more treatment now, last couple of weeks of chemotherapy, which were on hold before. So I see a trend that patients are getting comfortable, and we are, with our whole system set up, as I mentioned earlier, in the office, that they are getting more and more comfortable, and we're doing the treatment now more frequently than a few weeks ago or a month ago.
Jack?
Yeah, I think the challenge is we really don't know. I mean, we're making decisions that are based on what we believe are the benefits of our treatments, and now the additional risks of COVID-19. And we feel that these risks have heightened the risks of the treatments that we give, but we don't know if we're impacting outcomes. And there's been, discussions even in the New England Journal about, are we hurting cardiology patients and oncology patients by delaying treatments and procedures? I think there's situations where it's perfectly appropriate. Like, for example, somebody in their 70s getting hormone therapy for prostate cancer, probably their testosterone is already suppressed. Pushing back a hormone treatment for a month or changing a 1-month treatment to an every 3-month treatment is likely not going to hurt them. But if somebody has a node-positive colon cancer, does delaying adjuvant chemo have a detrimental effect? We just don't know. I think in terms of the screening delays, there's a couple of things that we worry about. One is the backlog. I read the other day that there's 130,000 mammograms and 50,000 colonoscopies performed in this country on a daily basis. So that's a lot of tests that are getting pushed back. Many will not show cancer, but some will. So diagnosis will get pushed back. And then from a patient perspective, there will be patients out there who are fearful, even when screening opens up, to come to a hospital or come to a site to have the screening performed. And that could lead to the diagnosis of more aggressive cancers down the line. We just don't, these are things that we just don't know the full impact of.
Yeah, I think there are a lot of issues that are obviously ongoing, as all of you have been addressing. We've had a couple of really good questions come in. I think we've addressed a couple of them. But I think there's, if I may sort of paraphrase some of the questions, there's an overarching theme out there, and that's our message to our patients. How do we approach the patients? How do we explain all of this to them? The testing issue. So we already have some questions about, it appears that some centers are able to offer testing to some patients, but not ours. And that can have an impact on how comfortable someone feels about coming into a center. We just heard that Stanford has stopped doing the basic screening with the temperatures and all of that. And I always thought that that was not really all that helpful. We do it at my center also, but I'm not really sure how effective of a screening technique it is. So if you have a patient who is, let's say, newly diagnosed, just short thoughts from each one of you as to, first of all, how do you prefer to approach that patient? Is it the in-person visit your preference, or is it, are you comfortable with the Zoom for a new patient? And also, when you do bring patients to the center, if they have questions, what kind of resources your centers and your offices might have for them in terms of where they can go to get additional information about the testing and the antibodies and the differences and all of that? Because can't imagine you guys having enough time to sit there and go through what an antibody does and all that. Are you providing those kinds of services for the patients?
Sure.
Go ahead, Dr. Abbasi.
I'll take this question. So to answer your question first about in-person meeting versus Zoom first-time patients. So we in our practice decide, and individually also, but generally the consensus that anybody who's older and frail and have issues understanding, we prefer to do Zoom meeting with the family around them so that they can be participating in that. Because if you bring somebody into the office and first time meet them, especially diagnosis like cancer, it's very uncomfortable talking to a person who elderly otherwise, and in maybe potentially not understanding, or sometimes family wants to protect them against getting bad news right up front alone, and which can be very understandable. So I prefer those kind of cases. Of course, we ask the patient what they prefer, but most of them prefer to be around the family when they're discussing these nuances and new kind of diagnosis. To answer your question about testing, again, being a physician-owned practice, we are able to make some decisions very early on. And I mean, of course, we don't have to get too many kits or supplies for too many patients. So first we started by providing kits very early on, within first week, for our staff to make sure they are not infected and they are not infecting the patients. So that we did in the very beginning, just to check some of them who potentially were exposed or stuff like this. Now that the antibody test is available, and we are partnered with one of the private company lab, BioReference, which are doing actually on a bigger level. Some of the towns in our area, whole population is being tested by the antibody test. So that resource we have available. So we actually are offering to our patient, when they come to the office in Park and Poke facility that we have outside, they come and they do the testing, and that most of the time that test is available within 24 hours actually, which is surprising. They give us 3 days notice, but we get next day usually the antibody, and that tells us whether they were exposed. If they are IgM, that means they're recently exposed, or the IgG, whether they are remotely exposed. So it can be helpful in case-to-case basis, especially patients who we think will need chemotherapy soon. So it's a good idea to at least have some idea to get those things. So those are the couple of things that we as a physician-owned practice are able to implement very quickly without any red taping or going through all the different avenues.
Good. Dr. Leighton?
Yeah, testing is a work in progress for us. I mean, we do have the capability of doing the nasopharyngeal swabs and PCR testing through our primary care practices. We haven't made decisions yet about formally testing patients who are starting treatment. Hopefully we'll do so in the near future. We don't have antibody testing available yet, which I think would be quite helpful. In terms of our new patients, we are doing all new patients through virtual visits, but I think to make a decision regarding treating a patient, you do have to have them come in. So we'll do the first visit virtually, but the second visit, especially to make sure they're appropriate for treatment, and to make sure they understand the rationale for treatment, potential complications for treatment, we will bring them in. We do encourage them to have folks available on their phone who can listen into that conversation. And then obviously, if we're giving in-office treatment, future visits would be in the office.
So Dr. Mann, I'd like you to answer the same question, but I also have something else. I think I heard you say that your radiation oncology department started testing patients who were coming in. Was that just the new patients? Or, I mean, if radiation is every day, you can't possibly be testing patients every day, or are you? I mean, because they go and come back.
Right. I think with the beginning of the shelter in place in California, so this was beginning of March, the radiation oncology patients were being the first to be recommended to have testing. And this is not testing every day. I think this is like testing before the start of treatment, again, because they were expected to have a lot of visits, you know, in and out of the center. But you know, to speak to the question about testing, again, part of this reflects just the resources of the community and of the medical group. So Stanford has clinics throughout the Bay Area, which are designated clinics where patients can go for testing. So some of this is somewhat like drive-through, or, you know, testing the way Dr. Abbasi was describing. So drive-through for the swab testing. And then there is the option now, we didn't have this earlier, of getting the antibody testing through Stanford. I mean, I've had a lot of questions from patients about whether they should try to get the antibody testing. There's commercial labs that offer it. There's a lot of options, and I am quite frankly confused about the sensitivity and specificity of these tests. There seems to be a lot of variability. So I have been advising patients that I'm not really sure about which ones is the best test to use. And on top of that, you know, when some of these tests are not FDA approved, patients are paying a lot of money out of pocket sometimes, sometimes several $100s for the test, and then a phlebotomy fee. But that may change as now, you know, Stanford's opening up their own assay for patients.
Great.
It's an interesting question about, you know, the cost that you brought up. I think as, I don't know if you've seen this yet, but, you know, we already have a big issue with our patients who have Medicare and not good oral medication plans being able to afford expensive oral targeted therapies. And you know, with the issue of unemployment and people who are clearly suffering from the furloughing, et cetera, it's going to be an increasing issue. I don't, you know, a lot of the questions that have come in, both in this town meeting and others, is do you choose oral medications instead of IV medications now? Does that make a difference? In general, you know, oral medications have their own sets of toxicities, of course, other than endocrine therapy for cancers that respond to endocrine therapy. But I wonder if you've seen that, and has that been an issue for you? How are you managing that in your practice? I don't know.
I can start again. So I think early on, I would say that there was a push from us as the physicians also of doing changing from, for example, 5-FU to Xeloda, just a simple example, and putting somebody on hormonal treatment if they can for breast cancer, rather than doing chemo in the beginning when they actually needed chemotherapy, just to delay it a little bit until things settle down. But things are changing, especially now that we are very comfortable seeing our setup and flow in the office and the way we are dealing with the patients with quite a bit of protection. Both staff are more experienced now. We are seeing the things. So we are able to now do the chemotherapy IV wherever it is needed. So I think in the beginning, there was a lot of scare, but things are changing. Wherever we can, honestly, we are changing to oral, but if there is in our heart, we feel that IV is better, we are doing it with confidence that our situation setup that we have is good enough that we can proceed.
It's interesting, the NCCN modified the GI cancer guidelines and did suggest moving to more capecitabine oxaliplatin for stage 3 patients. We have a specialty pharmacy in our cancer center who does a great job in getting oral medications for patients, but at least for the patients that we see in our center, K-Box is not a picnic. They get 135 milligram per meter squared of oxaliplatin, which is a good dose. It is every 3 weeks, but there can be toxicity from that. And then you throw on staying adherent to the capecitabine, it can be a challenge. So we still do a lot of IV, and we try to personalize these decisions based on the patient and their support and comorbidities.
So do you guys have like a specific formula in mind as to how you prioritize? Do you think that some of the recent guidelines are helpful in terms of deciding who to prioritize for what therapy? And that's, again, a question that has come up a lot, for patients with different kinds of GU malignancies or different kinds of GI malignancies. Are you saying that everybody with pancreatic cancer has to be seen immediately? Or, are there guidelines that help you? Jack, it seemed to have something about that.
Yeah, the NCCN updated the colorectal, and one of the other interesting features of that is they bring up the concept of neoadjuvant chemotherapy for patients who look like they have node-positive colon cancer. And we had this discussion in our multidisciplinary conference this week and with the patient, something that we typically don't do outside of rectal cancer. But I think there's a concern right now in a hospital with a fairly high COVID positive population that once a patient comes in for surgery, they're in the hospital. And if there's unexpected complications, that can keep them in the hospital. It's almost like chemo in some ways is safer than surgery. And I think these are decisions that are not made by one person. They're made by a team. I think pancreatic cancer is a disease that unfortunately requires almost immediate decisions. Other diseases, I think it's by stage and biology and what the patient is up for.
Dr. Mann?
Well, I would say part of my practice is because it just reflects that we have not been as hard hit by the COVID pandemic here in California. I mean, in general, for patients who look like they have curable cancer, I've just been trying to move forward with the usual care, trying to get them timely adjuvant therapy, trying to get them just the, timely treatment in general. Now, of course, with breast cancer, there is the option of neoadjuvant treatment. So I had been instituting more of that, although more recently, again, Stanford has opened up to doing surgeries on a more regular schedule.
Okay.
Yeah, I will echo what my colleague said. Just to add on, most of us are getting calls from the surgeons we being a general oncology practice, we see all kinds of cancers. So I actually recently treated a colon cancer patient, which clearly stage 3 patient who needed surgery first, but we ended up deciding to do chemotherapy because there was no way the surgeon would have done the surgery. So that's pancreatic, for example, you asked this question about pancreatic. Depends, case to case basis, but if somebody has a very bad stage 4 pancreatic cancer, we have a real, an elderly patient, for example, a real discussion about palliative care versus going for chemotherapy. And in some of those cases, maybe we have done chemo in usual circumstances, but considering the whole risk and to the patient and the caregivers, we sometimes have decided to proceed with no chemo or no treatment in palliative care. So it's case to case basis, but most of us are getting calls for neoadjuvant treatment from surgeons literally on a daily basis on these patients, either breast cancer, colorectal, of course, and some of the pancreatic cancer patients who are locally advanced disease.
I wonder how we're going to be moving as we move forward, how we're going to be opening up our treatment and, how we're going to deal with questions from patients. One of the things that's come up a lot recently as people have seen, states opening up and, but also trying to maintain social distancing, the question about masks, et cetera, is, now can patients plan their holiday? Can they travel? Are they more immunosuppressed because they're getting treatment? And so therefore they shouldn't be traveling? Should they have their grandchildren visit? How are you all handling that question? I think the grandchildren visit and plane flights are probably the biggest questions that I've been getting recently. Hossein, what do you tell patients, Hossein?
Yeah.
Patients are dying to see their grandchildren.
Yeah. So no, my standard advice has been to follow the guidelines as have been discussed by CDC and everyone else. We're still practicing.
Patients hate that though.
I know. I know. I mean, I have a 90-year-old father and a 78-year-old mom who live 5 minutes away from me. I have a 5-minute drive, right? And it is very challenging for them to understand why we cannot go and see them on a regular basis. So I do go and stand on the porch and say hello and make sure everything is okay, and do all of that kind of stuff. And my kids who are home, and my kids are older, they've been practicing social distancing, and I think things are safe. So I think it's difficult for everybody to do this, but especially for a patient with a malignancy who is on active treatment. I think the discussion is, this is for your own benefit, and it is to protect you and the rest of the family and everybody else who might come in contact with you. And therefore, it is of paramount importance that you maintain the social distancing, particularly with little kids when, they can be asymptomatic, they can be exposed, and most of us would not know it. In a country where we do not have universal testing, it is difficult to open things up without all of these precautions in place. So I am very hesitant about allowing patients to visit family members or have people come over. So we do it. It's hard for us, and that's one area where we can really identify with our patients. Most of us have not experienced what it feels like to have platinum chemotherapy infused into us. But most of us can experience what it is like not to see your parents, your loved one, your kids. So I think that's one area where we can definitely identify, and it is painful and it's bad, but it is necessary, unfortunately.
So let me just ask another question then of the group. So one of the things that, and I think this is true of many malignancies and focus on breast cancer only, but we have a group of patients who are reasonably well. They're on oral therapy, often hormone therapy and CDK4/6 inhibitors or other targeted agents, sometimes on antibody therapy. But they have metastatic disease, so that they know that their survival is short. And everybody's been sequestered now. So they're using up their valuable remaining part of their life, not doing anything. And so the question is, how do you vary your recommendations in that situation? We don't know, for example, that taking a CDK4/6 inhibitor puts you at higher risk of having a worse COVID infection. We haven't seen that. There's no data suggesting it. Certainly we know if you have terrible lung cancer and you're on, a lot of IV chemo, that's a big risk. But how do we balance what we want to do to protect our patients based on really taking away any quality for their life, when it's relatively shorter? Martha, how have you faced that issue?
Well, that's a really interesting question. I think it's a balance, right? I think there's still a lot of fear from patients about risk of getting COVID, so even if they were offered the option of perhaps traveling or doing something, a lot of my patients, I think, are just not comfortable with that. They're not even comfortable about going into a restaurant or something. I mean, not yet anyway. I do have to say, I agree with Dr. Borghael that I've generally been saying, you should not be traveling. You should be staying inside. You should be trying to avoid interacting even with other family members. Unfortunately, I guess I personally have not had any hard discussions about limited life expectancy and how you're spending that time. That's a great point.
I think some of that becomes patient preference. I mean, this definitely is another one of those shared decision-making processes that we go through now a lot with our patients because of different treatments. Look, yeah, I understand limited life expectancy, and that's really difficult. And yes, we do have a lot of patients on oral agents, where even with metastatic lung cancer, who are doing really, really well. We just had 2 other oral agents approved for MET and one for RET. I mean, the world looks good, and these drugs are very effective. They're not toxic. It's not that the treatment necessarily increases the risk. Actually, there's data from Italy and other places where whether you're doing chemotherapy or immunotherapy, the the unfortunate death rate of COVID infection doesn't really change, at least based on those treatments. But it's the fact that patients who have a known active malignancy just have worse outcomes compared to patients who do not have a malignancy when they do have a COVID infection. So I think as physicians, it's always our jobs to, or part of our jobs to advise patients on what we know in terms of risks and benefits, particularly in cancer. There's risk with chemo, but there's benefit. There's risk with oral agents, but there's benefit. And it's the same discussion here. There's risk with going out there and traveling and, just act like your life is as normal. There's a little benefit to it also. So I think then that becomes a decision. The problem that I have is that it's more of on a social basis. If I have an infection and I go out, I have the potential to infect a bunch of other people. So how do you balance that? And it's the good of the society versus the good of the individual, which is one of the everlasting discussions we've always had a conversation. So those are the kind of things that I discuss with them. I don't ban patients from going out. I mean, I can't. So if someone comes and says, look, you told me I have 6 months and this is what I'm going to do. Of course, I'm not going to stand in front of them, but you just have to have that open discussion with them.
One of the really nice things is, you talked about infecting, that we could affect other people. I think in the beginning, particularly in the first month or so of the COVID pandemic, it was a huge stress for healthcare providers of all different kinds, particularly our colleagues working in intensive care and the emergency room. And we really did see the impact of that. I think now that universal masking and screening has been employed, and also patients have access to testing if they have any symptoms at all, it seems to be better. But perhaps that will be something that will help, I think, moving forward. I think one of the messages that we got recently in our, sort of general stream on COVID was, remember, you should take your mask off when you're doing a Zoom visit. So it was so funny. It was like, right, when I close myself into a room when I'm going to see a patient, so it's a usual visit room, and I do my Zoom visit with a big computer because nice, it's a big screen. I have another computer where I can see the patient. You take your mask off. It's really unbelievable because I can actually put a translator online through an iPad that's separate. The electronics are amazing in the room. You have to bring 3 devices in, but it's interesting because in my experience, first they can see your mouth moving, which is, Martha made that's such a nice point about that. The interactions are so different when people who are old and people who can't hear well, it's not just the emotions, they actually can't tell what you're saying. And I use, that a lot to understand when I'm not hearing well a patient, but also, the family members can be all around the patient and translate and go back and forth. And even it's so funny because, we even have situations where the husband and wife are arguing about what their symptoms are on Zoom, which we usually see in person. Yeah. So that can be a lot of benefits.
Yeah, my problem is that everybody tells me I look better with the mask on, so I keep it on even for Zoom meetings. So there's another question that has come up, and I think we've touched upon it, but still is being discussed. I think we can phrase it as, do you do a bridge treatment, for instance? So the exact question is, have you seen delays in getting testing results? If so, how do you decide what treatments to give in the interim? So testing delays, I have seen it, but it's usually like a day or two. It is not a prolonged testing delay. And in those situations, obviously, I just wait until the test result comes in or repeat it. So it's usually not more than a week. Have you guys have to wait a lot longer, Dr. Abbasi, in terms of test results coming back?
So depending on what test we are talking about, pathology or PET scan or CAT scan, with some of the...
Yeah, any testing.
Yeah, so for example, a lymphoma patient I knew need to be treated, and I didn't have all the things supposed to be done. PET scan was not done, but I had enough information based on the CAT scan. Echo, I was able to get it. So I think it depends on what cancer we're talking about. So if somebody has small cell lung cancer, you don't need to worry. As long as you have diagnosis, you can move ahead and through the treatment. But it's real. Actually, there are some patients who we had to wait for some pathology, for example, and you're debating whether we know what it is based on markers. I know this is, for example, a patient of mine had CA19-9 was very high. And I know either it's pancreatic cancer or it's cholangiocarcinoma, but we didn't have the tissue. And we actually struggled to get the tissue, and eventually we got the tissue done. But that was a challenge because we are delaying this treatment because we didn't have the diagnosis. So yeah, that's challenging at some time.
Jack, have you seen any delays in getting some stuff back?
We get the stuff back quickly, but I've had several patients who've not wanted to go get the test done. And so it makes us rely more on our clinical skills, and I think a lot of times when we get a scan, we're not too surprised by the results. I think we tend to know who's doing well. We tend to know who's not doing so well. And I think, in the last few weeks, I've had patients say, I'd rather you keep going with the treatment and not do the scan. And I've had, this week I had a patient where I did insist on the scan and I did have to recommend hospice to the patient, but I felt that they would not make a decision towards hospice without the scan. While I've had other patients who I have a sense that they are doing well, say, yeah, let's try to push the scan back 1 or 2 cycles and keep going. So we get the results back quickly, but it's more who are we ordering the scan on.
Martha, have you noticed anything?
Yeah, no, I would agree with Dr. Leighton entirely. I don't think there has been a problem getting the tests or appointments scheduled in a timely way, but you're trying to be maybe more judicious about who really needs to have these tests. So maybe instead of doing your routine, 3-month scan, if the patient is asymptomatic and feeling fine and wants to reduce their risk of exposure, pushing that out a little more, giving a little more laxity. But obviously for symptoms or important decisions like end of life, then you just have to get it done.
It's actually easier to get them scheduled now. There's more holes in the radiology schedules, so you can get them done quickly.
Yeah, actually, some people recommend the tests and they are not going because the facility is in the hospital.
Yeah.
And I had several patients like this who had delayed.
Refused to go. Yeah. Dr. Rugo, you want to bring up the idea of end-of-life care and how do you manage it and whether you do that on telehealth visits or not?
Yeah, I think this is a big question for all of us. I think oncologists, unless they specialize in palliative care, generally are, hate to discuss end of life and hate to, make that, have that conversation with patients about that it's really time to stop active therapy and really work more towards supportive care for the end of life. And I think that's been evident in data that has suggested we use hospice not as well as we should and often very close to the end of life because, and as we've had increasing options for care, that's been a big difference. We have had, I think, questions that have come in from patients about whether or not, because they have cancer, they wouldn't be able to receive care for COVID-19, for example, or they wouldn't receive the same cancer care. I haven't actually seen that on the West Coast, so I'm interested in whether you have on the East Coast or whether there's a difference for specific patients, because we have not changed our treatment plans for those patients. The second part is how you actually do visit with a patient where you are talking about those issues, or, for example, breaking the news that a patient has newly metastatic disease. I have 2 minds of it, because in some ways, if they come in all by themselves or with a single family member and don't have anybody there, that's really difficult. With Zoom, we can't hug them anyway. But, and we have masks on, whereas with Zoom, you have the mask off and they can have all of their family members around them. So there may actually be some benefit in the long term with this approach if we can't have the touch with patients. I saw a really very poignant story, one of the many articles we've all read about COVID and patient care, about a palliative care physician who would always offer a spoonful of honey as a way to sort of give that act of kindness in a situation where a patient was at the end of life, and that not being able to provide that was such a big difference in care. But I think that we may be able to provide very, very supportive care in different ways. So I'm interested in all of you and your thoughts on these different areas. Do we reduce the care in patients who have metastatic disease that where they clearly have a short survival, both oncologic or COVID-19 care? And how do you best break bad news to patients? Jack?
In terms of what treatments to offer, I think, again, I think the bar would be higher with salvage therapies today than it used to be, when the potential benefit of a salvage therapy is minimal and somebody could, if they got a COVID-19 infection, possibly not survive that. We've been more fastidious in bringing out our advanced directive packets for patients starting treatments. We've had variability with that, but we're making sure that all patients have information about advanced directives when they come in for treatment. We haven't been in the situation where we've had to treat somebody with a COVID-19 infection. In terms of the end-of-life discussions, obviously that's always better in person, but right now it's not always realistic in person, and I think that becomes an individualized decision. The discussion we had this week was over the phone with a patient, but it is a patient where we had laid the groundwork before, so it wasn't a shocking discussion to the patient, and we did wind up setting up hospice that day. But we've had a couple other patients in the past week where we knew we could not have this discussion over the phone, and we bring them in. And in one situation, I did allow a family member in the room because I thought we had to do that for this particular patient. So it's very difficult. We've had great support from our palliative care team, who is working remotely and working extremely hard doing consults for us. So we do have a lot of support with our patients, and we're all just adjusting to this situation.
Dr. Abbasi?
Yes, sure. I would say a couple of points here. Number one, as probably all my colleagues, all of you have experienced this, the cancer patient when end up in the ER, especially stage 4 cancer patient, there is a difference in the dealing with those patients, especially in crises like this, when as soon as the ER physician finds out that this patient is stage 4 cancer, they're usually already thinking about hospice. And so many times we got a call, look, this is a stage 4 patient with possible COVID, why don't we just talk about hospice right away? And knowing what we know and so many things that are available these days, oral drugs and other drugs which are targeted treatments, and some of those patients haven't had some of those treatments yet. So you have to literally open the whole this discussion about, look, this patient hasn't received this and that. Some of our colleagues in the ER and even internal medicine sometimes have difficulty understanding why in this crisis you're talking about a stage 4 patient and not talking about hospice. So that sometimes I feel that you have to have a little bit extra discussion with our physicians in the ER. Number one. Number two, yes, actually we recently had an experience in my group. We offered our services to the hospital, to hospital where we go, to palliative care, because there are a lot of people who are dying in the hospital with COVID infection and family not allowed to. And the physician who are actually up front dealing with the COVID situation, they are too busy to talk to families. So we offered our services and we went in person, but also on the phone to the families and spent a lot of time with the, occasionally what we have done is that both patient are personally there with the mask on, but have a video conference call in the family members so they can at least have some kind of presence. I had a patient in the office, I had a discussion with this. So because family member cannot come in, what I did is that person I brought the Zoom, in fact, FaceTime, I did the person on the phone, family members, and had discussion, combined both in person with the elderly person in the room and had a Zoom or a FaceTime with the family. So yes, I've kind of come up with these innovative ways, but I agree, I'd rather have no mask on and talk to the person with my eyes, my lips, my body movements, and gestures to comfort them about this difficulty. That for me is much more important than sitting across with a person with a mask on and literally can't touch 6 feet away. So I think if I have a choice between the two options, I would prefer, to be honest, at this point, do a Zoom discussion, especially if there's the possibility of family around the patient.
Sure. Dr. Mann?
Well, again, I would say in California, I've not seen circumstances where I felt like we had to ration the cancer care or pull back on certain treatments for patients with metastatic disease. I do echo Dr. Abbasi's concerns that, you know, practitioners in other specialties may not have the same perception or understanding of metastatic cancer that we do. I mean, we have metastatic cancer patients who can live for years and actually have years of life expectancy. And so it's not like we should automatically stop offering them, you know, appropriate short-term care for infections or other things when they come to the emergency room. As for the question about the end of life discussion, that's been a difficult thing. I will say my personal preference would be to see the patient in person. In my clinic, we have been allowing at least one family member to accompany patients for those kinds of discussions. And I do agree that's not ideal. Sometimes there can be many family members who, of course, want to hear the information and be involved. But I still feel like there's aspects of live communication that I can do better than through the video.
Yeah, it's interesting. I mean, I've had now been offering family members that they could Zoom in to the visit so that they can see and be on video, which I think might be something that we could continue to do. Although I think with testing, we'll probably all be opening up the ability of having patients bring family members in. One of the questions that's come in is how you deal with palliative care. Obviously, you were providing, Mohammed, the palliative care in your hospital, but do you consult palliative care doctors? Do you have them available to you in practice? Martha, do you?
We do have an outpatient palliative care service that does practice in our clinic. It sounds like Dr. Leighton offers that same kind of option, and they can be a very useful adjunct for, of course, not just the end of life discussion, but, you know, symptom management and emotional support. I do practice out of 3 different hospitals in San Jose. One of them does have really outstanding inpatient palliative care, although the others do not. So kind of like Dr. Abbasi was saying, you're kind of acting in that role as well when you're going to those particular hospitals.
Yeah. So I think in the remaining time, maybe we can go around the virtual table and sort of provide our sort of final messages, at least for this event. We're hoping that we can get all of you back in our subsequent programs as things develop to sort of see how everything has evolved. But any message that you have at this point, first of all, there are a lot of questions online from your colleagues in the community with very real issues, much of which you guys have touched upon. So thank you for answering those questions. But there still are a lot of questions out there, obviously. So I think your colleagues and we absolutely appreciate it. And there's a lot of questions from patients and patient advocacy groups about how you handle the situation with your patients. And again, I think you've done a wonderful job of covering all of that. But let's see for the remainder of the 5 or 6 minutes that we have, if you can go around the virtual table and give us your final messages and what you're hoping to see in the future. And then hopefully we can come back together and talk about whether we got there or not. So let's start with Dr. Mann, since you are on.
Sure. Well, I obviously it's been a stressful time for all of us, for the patients, for the providers, for the staff. I guess I feel like I've been just trying to soldier on and try to offer the best possible quality of care as close to the guidelines as I can. I fortunately have not had to deal with much delays in care or lack of access to procedures. And more recently, I've been fortunate enough to have access to better testing for patients. So I remain optimistic that at least in California, things have recently been starting to open up in terms of the medical centers, and that hopefully will be in a better position in a couple months.
Great. Dr. Leighton.
Yeah, I think what Dr. Mann just said is really important. I mean, the situation is really stressful to everybody. It's to the patients, to the families, to our teams. We've gone through furloughs, which is challenging. We look forward to the day that we can become used to practicing as we have been. We're trying to prepare for a surge of patients because there's always concern how we're going to get everybody in. So we've started to move up some of our follow-up patients who can be handled through remote visits, maybe move them up 2 to 3 weeks, get them on board. They don't mind having the appointments moved up because they're typically at home. And then it allows us to let the referring specialist and their patients know that when the time comes that they need appointments, will be available for them.
Great. Dr. Abbasi?
Yes, thank you. Again, thank you for the opportunity. This is a great experience. I would say I have a message of hope, Dr. Hope, right there, is that from her actually, that there is good things that are coming up. I think the way that we started this whole pandemic in US, I feel is the tide is turning. I think the very important message I want to put across this forum is that the patients, they need to talk to their physician. There's so much social media actually helpful, but many times it's very distracting. So a lot of people are getting information, no mask is not needed and all those things. I actually have to personally talk to some patients who were refusing to wear the mask, which is unconscionable in this situation. Even if it's not helping, you have to be responsible. So I think very important thing is that the patients, they have to talk to their physicians who are the caregivers about any decision they want to make and trust them, because we are the front in the front of the whole this problem. So we have to make sure that our patient understand clearly what are the stakes. So I think hope is there because we have antibody testing, which is available more. I think clearly there more and more testing is available. So hopefully by doing that, the more patient will be feeling comfortable continuing their treatment, and hopefully that confidence that has to come from us.
That is great. Dr. Rugo?
Well, I think, first I want to thank Axiom for doing these town halls and the other groups that have been doing them. I think, providing information and the perspective of oncologists around the United States and internationally has been an enormous service to the community, which I really appreciate. We've also done a Zoom forum in the Bay Area that many patients joined in on, which I think is really helpful. So providing information that counters some of what we see on the news. I think many people just became news junkies. You can look at everything on your phone now, and people it just kind of raised everybody's anxiety levels. We clearly need to be careful. Clearly practice has changed for the long term, not the short term. We can't have crowded waiting rooms. We need to stagger patients coming in. We need to think about what we're doing in a very careful way. I think that when we can do a visit by Zoom, it's not only a protective area for COVID-19, but it is also something that's kinder and gentler for our patients in some situations where patients are, well, they don't have to be driving in. And you can imagine, this is saving for many patients 2 or 3 hours of time. But we do, on the other hand, need to treat our patients. We need to provide the best treatment we possibly can. We've made huge advances and we don't want to lose those. I don't think we need to. I think that we are in a time of hope where we can use what we've learned and are learning to improve our care for our patients and improve their quality of life, protect our patients and protect our healthcare providers at the same time.
That's great. Yeah, I agree. I think there are a lot of changes that are here to stay, and I think they're good. I was on another Zoom call yesterday with a colleague from Hopkins, and they actually have a drive-through shot clinic now where for patients, for instance, who are on hormonal therapy for prostate cancer, you come in, you get your shot and you go. We've seen images of drive-through testing facilities. I think those are probably kind of models that we're going to be using for future for different level of testing. I can imagine like doing labs. If somebody needs labs and they're on their way to work, they can come in, stick your arm out, we do the labs, you go to your work. I mean, who knows where we're going to be with all of the changes. I think the telehealth, there've been a lot of discussions about telehealth and how we can expand the reach to patients who don't have access, but there are always struggles, and it is amazing that when there's pressure on us, how quickly we can move and enact rules and regulations, and as Dr. Mann said, codes to get the right charges and all of that. I mean, all of these things virtually happen in a matter of a couple of weeks, maybe a month. So I think these are good positive changes that are going to stay. I think all of us are going to have to adopt to new changes, whether I like televisits or not. not. It is something that my patients want, and I'm going to have to do it, and I have to get used to it. So I think those aspects of things are all good. And I do believe that we're going to find a solution to the COVID, whether it's an antibody or it's a vaccine or a drug, and we're going to come on the other side of this. But I do also agree that we've changed as a profession and as a society and as a world, really. So it will be interesting to see what the post-COVID era looks like. Again, I'd like to thank all of you for joining us. Dr. Rugo and I have done this 2 or 3 times. We always learn. I always learn something new every time we do this. So this was very, very good for us to see how our colleagues in their community setting are doing it, which is obviously a lot different than in the academics. We got a lot of really good questions. And again, I hope that we can come back to you guys later on for future programs. So have a wonderful weekend. Enjoy it. And thank you.
And I also want to thank everybody, thank our colleagues at Axiom for making this possible and organizing, everybody giving up their time on a Saturday. And for those who have people to celebrate Happy Mother's Day with, Happy Mother's Day to you as well.
True. Happy Mother's Day. That's great.
Take care.
Great. Bye,
Thanks.
guys.
Bye-bye.